Good morning and welcome to the AMA Future of Health Immersion Program, part of the AMA Steps Forward Innovation Academy. If this is your first time tuning in for a session, this program is a self-guided curriculum of webinars, didactic presentations, podcasts, and virtual discussions designed to support physicians, practices, and health systems in optimizing and sustaining telehealth and digital care modalities at their organizations. My name is Laura Fricci, Project Administrator for the Digital Health Strategy team here at the AMA. And today we're partnering with our behavioral health integration team to discuss digital therapeutics and bring you some case examples of this work. If you could go to the next slide, we have a quick disclaimer that we'll share. And you can go to the next slide. I'll begin by introducing our speakers today. We have Chris Botts from the American Medical Association, Lanny Hesson and Pooja Ragani from the Digital Therapeutics Alliance. We have Dr. Kyler from Freespira, Dr. Aloof from Limbix, and Dr. Godquitz from the University of Pittsburgh Medical Center. If you could go to the next slide. For our agenda, we'll start with Chris giving an overview of digitally enabled behavioral health integration, and then we'll have an overview of the digital therapeutics, and then we'll go into a couple of case examples, and then we'll wrap up with group discussion and a wrap up and close. And I'll pass it to Chris to kick off the overview of digitally enabled BHI.
Thanks so much, Laura. Really appreciate it. And so excited to have all these great folks together for this important discussion. As Laura noted, just going to give a little background about some of our digitally enabled BHI work here at the AMA, as well as those related to the Behavioral Health Integration Collaborative. We've had a few sessions within the Future of Health series, so those are interested can search for those as well for additional background. Next slide. So just as a brief introduction, the AMA, along with 7 other leading physician organizations, created what we call the BHI Collaborative back in 2020, which is really a collective effort to focus on catalyzing effective and sustainable integration of behavioral and mental health care within physician practices, with initial focus within the primary care setting. And really the focus is finding ways to help physician practices in these settings identify and manage at least mild to moderate conditions as a core competency of what they're providing for their patients. And you can see a list of all the members of the collaborative down below, but it covers the range of primary care related specialties from pediatrics, OBGYN, and psychiatry as well. Next slide. And as part of our work, we really focused on looking at digitally enabled behavioral health integration models. I think as many folks know, there is a behavioral health crisis occurring in our country that's only been exacerbated by the COVID-19 pandemic. And behavioral health integration models are one key solutions to tackling that crisis. And there really is an opportunity to leverage digital tools to increase the adoption and effectiveness of these specific models and addressing some key barriers that we've heard constantly from our physician practice partners. It's also really important to understand that this is a team sport and that all the various different key stakeholders within the space, not just the provider entities, but also health plans, employers, policymakers, digital health companies, and others really have an important role to really work together collaboratively, collectively, in order to make a difference and create the reality of care that we're all striving for patients that desperately need access and treatment for themselves. And the last piece is the return on health framework that the AMA released that really focuses on value streams of how to identify how digitally enabled behavioral health integration can be measured in its effectiveness and value. And there's a link at the bottom here for those folks that would like to read that report. Next slide. And as part of the report, we identified several opportunities where technology can play to support behavioral health integration models. And that includes enhancing patient experience and treatment, supporting integration and limiting fragmentation of care, which is unfortunately the more standard way that patients experience our care system to date, and ultimately generating value for patients and the provider care teams that are really striving to help support their needs. But there are some key limitations that we identified as part of this report, one of which is the fact that technology cannot and should not replace the need for in-person care, that rather technology can amend or augment in-person care or fill in key gaps where necessary. But there isn't a situation where all care should be done purely virtually. There still is a need for that in-person experience. There also continues to be a lack of clinical or economic evidence for many of these technologies, and there needs to be more efforts to support the major regulatory and coverage decisions that are being made. There just is a huge gap in that database, and we may talk about that a little bit later in our discussion portion. And there's also an understanding that technologies just aren't appropriate or available for all persons. And so that's just something to keep in mind as we're thinking about reaching various different patient populations and settings, that there's opportunities to use technologies, but it's just not going to work for everybody. And that includes issues around broadband access and other kind of major issues that goes beyond this specific discussion. Next slide, Sam. And as part of the report, we identified opportunities where technology can support and add value to the behavioral health integration model and the patient journey. I'm not going to go through all these various different digital tools because we covered them in depth in a prior session, but just wanted to call out where digital therapeutics can potentially play a role within this integrative model. And looking forward to hearing more from Freespira and Limbux and the DTA team as part of how digital therapeutics can add value and more coordination, collaboration across this specific journey. And with that, I believe there's just one more slide, next slide. And as kind of discussed, it's important to think about the true value that these type of digitally enabled models bring to the table, again, both ultimately for patients and their care teams that are serving them. And so this is a framework that the AMA developed to help identify the value of these specific kind of integrative care models. And it's important to think about all these different value streams together that can really, truly make an impact for those that we're trying to serve. So with that, I will pass things over to Lanny and Pooja at DTA.
Hi, everybody. Thanks so much, Chris, for that background. I will continue a little bit with background on what is the DTA, the Digital Therapeutics Alliance, and what are digital therapeutics in general. Again, I'm Lonnie Hessen. I'm an occupational therapist by professional training and have been involved in the DTA for the past year or so, and happy to be here. So thank you. Go ahead to the next slide. So we are the Digital Therapeutics Alliance, and if you proceed to the next slide, we'll mention that we are the trade association of the digital therapeutics industry, and our mission is to broaden the understanding, adoption, and integration of clinically evaluated digital therapeutics for patients, clinicians, payers, and policymakers. We do this through education, advocacy, and cross-industry collaboration. So what that means is we bring together all of the stakeholders that I just mentioned in work groups and task groups to solve for barriers that exist within the industry. We do take some of our work to Capitol Hill to talk with policymakers and legislators about how we can provide access to patients. So that's our main focus, education and policy. Move to the next slide, please. So what is a digital therapeutic? This is the agreed upon definition at the moment. A digital therapeutic is a tool that delivers the intervention, the therapeutic intervention, to patients using this evidence-based, clinically evaluated software. And that software as a medical device is meant to treat, manage, and prevent a broad spectrum of disease and disorder states, which Pooja will talk about momentarily. These products can be used independently. They can be used in tandem with other interventions that are part of the patient's care plan. They can be used in person or remotely. So as Chris mentioned, this provides a really wonderful opportunity to increase access to patients who may not have regular access to in-person care. Go ahead and move to the next slide. So we think it's really important to help folks understand what a digital therapeutic is and also what it is not. So this slide gives a bit of an overview in terms of how we classify digital health technologies and who's looking at them during their professional practice. So over on the left, the first three categories are generally not patient-facing. Well, actually, the first two categories, excuse me, are not generally patient-facing. Those are in the background and help with things like clinical trial, perhaps management in the case of an enterprise system or support solution, or perhaps those technologies that support clinician practice. Maybe the EMR, although I know that we might have some conversations about how that does not support practice. But the idea is that a clinician service and support tool is not a digital therapeutic. It is more of a workflow type of product. Telehealth platforms also fall into that category. As we move over to the right, we'll see technologies that do face the patient. And the first category that you see that patients are definitely using in kind of wide disbursement are these wellness products, right? These are our apps that are direct to consumer. You can go directly to the App Store to download a lifestyle or wellness app. They do not make a medical claim, and they're not really supported by evidence. So these are things that, you know, might really enhance your day-to-day life, like a Calm app, for example, might really help you with mindfulness meditation or may help you to fall asleep faster. But that type of application does not make a medical claim to treat insomnia, for example. Moving over to the right, we have patient-facing diagnostic and monitoring tools. These are really used to look at data, monitor patients, how are they doing with their plan of care. They also may include some digital diagnostics, some remote patient monitoring tools. They may include wearables or sensors. Again, they are not categorized as a digital therapeutic because they're not providing the intervention via that software. That said, as we move over all the way to the right into what is a digital therapeutic, these are our products that deliver that medical intervention. They make a medical claim, and they are supported by clinical evidence. These tools may have as part of them a monitoring component, or they may have a wearable component that is attached to the software as a medical device piece. So it can get a little bit confusing, which is why we try to outline this, the differences here in this slide. And what we like to see are the evidence-generated devices falling into this category that patients are accessing. And on to the next slide. So this is a way kind of restating what I had said just a moment ago. And what we see here are moving over to the right-hand columns that the label claims and the evidence requirements and the regulation of the products to the right side of the slide really is what differentiates the digital therapeutic. And now we're seeing more and more digital diagnostics from the prior three columns. So the label claim has to diagnose or treat a specific disease or disorder state. The software itself has to generate that medical diagnosis or provide the treatment. The accuracy has to be validated, right, and meet the regulatory quality requirements that have been stated by the manufacturer while they're going through the regulatory pathways. And again, these are regulated solutions. So they go through the regulatory pathways, either here in the US or globally. There are, of course, other regulatory bodies aside from the FDA. Go ahead to the next slide. So you might be wondering what the value of a digital therapeutic product is and how can they help you in your practice. So we mentioned, right, that they use evidence-based and they're clinically validated. And they really have the ability to optimize clinical and health economic outcomes by delivering that high quality therapy to underserved populations, people, again, living remotely. Really important to think about the patient populations that don't have access to brick and mortar clinics, for example. Maybe people have a hard time commuting. Maybe people have, schedules that don't allow for them to access care for their child. And so they can't miss work. And a digital therapeutic might be helpful for that particular group. They offer convenience and privacy, and they really do help clinicians, even like myself as an OT, extend care for their patients. And they have the ability to lower overall cost of care by potentially preventing patients from going to a hospital when they might be managed from home. And with that, I'll turn it over to Pooja to talk a little bit more about disease states.
Thanks, Lonnie. I'm Pooja Rogani. I'm a psychologist by training with specialty in behavioral medicine and primary care behavioral health integration. I'd like to share with you the variety of disease states that digital therapeutics address. As you can see from this list, they range from diabetes to musculoskeletal disorders. I specifically highlighted mental, behavioral, and cognitive disorders such as substance abuse, anxiety and depression, and ADHD, to name a few. We can move on to the next slide, please. I think it's important for us to be on the same page about what is integrated behavioral health in the first place. A growing body of research shows that integrated behavioral health improves health and patient experience while reducing unnecessary costs in time, money, and time delays. Behavioral health clinicians often work right in the medical setting, or if not on site, they are thoroughly integrated into the established procedures, team, and information systems. Patients with chronic health conditions are more likely to have related behavioral health concerns and often find it easier to improve chronic conditions when these concerns are also addressed. Patients like the convenience of one-stop shopping, whether their problem is stress, mental health, substance use, health behaviors, or all the above. There's no real wrong door here. Patients feel it's also more socially acceptable and easier to access behavioral health care in a setting that they're familiar with rather than going to a specific behavioral health setting. And medical providers appreciate this too, having behavioral health partners available to help with problems the medical team may not have enough time or training to address. We'll advance to the next slide, please. We find that primary care is an optimal setting for patients to remain engaged with digital therapeutics for a variety of reasons. First, by integrating digital therapeutics into primary care settings, patients have greater access to evidence-based interventions that can be tailored to their specific needs with features like gamification, progress tracking, reminders. Digital tools can increase patient motivation and accountability, which we find improves health outcomes. And digital therapeutics can be used at different levels of care in primary settings. For patients with mild symptoms, a standalone digital therapeutic might be used. For those with moderate symptoms, perhaps the guided use of digital therapeutics can be provided alongside an in-person clinician visit. For more severe cases, we see a combination of face-to-face care or teletherapy with digital therapeutics can be used. Notably, digital therapeutics provide patients with access, again, to evidence-based interventions that can be delivered conveniently at lower costs than traditional face-to-face therapy. And this can increase the reach and effectiveness of behavioral health interventions, especially for patients who may face barriers to accessing traditional care. In addition, we find that digital therapeutics often have components that allow patients to monitor their progress, that provide feedback to primary care providers. And we find that this can facilitate collaboration between primary care providers and behavioral health specialists and improve their communication, which ultimately leads to more coordinated and effective care. So by enhancing the efficiency and effectiveness of this stepped care model, digital therapeutics have the potential to transform the way we deliver primary care. I'll say a couple more points about how digital therapeutics can also promote patient engagement in the absence of a clinician by providing, again, that real-time feedback, those reminders. We find that digital therapeutics can also reduce stigma associated with behavioral health issues by providing a discrete and private means of accessing care, which helps patients stay motivated and engaged in their treatment, again, leading to better outcomes. So we find that behavioral health challenges often present first or only in primary care, and digital therapeutics will allow PCPs to intervene appropriately. And we can move to the last slide here. We hope that this introduction has helped you navigate this emerging body of technology, and we hope that you can see how it's useful in your day-to-day care for patients. If you'd like to learn more, please visit our website, dtxalliance.org, or contact us at our email addresses indicated here. Thank you so much.
Thank you so much, Pooja and Lonnie. That was really helpful overview of both digital therapeutics and how they can add value to the behavioral health integration models. We're now going to go, if you want to move to the next slide, to a couple of case studies of actual digital therapeutic companies and their solutions and how they've worked within these kind of integrative care models. So the first one is Freespera, and I will pass things over to you, Bob.
Thank you very much. If you go to our next slide, please. Really appreciate the opportunity to speak to you about our company and intervention. Freespera just celebrated its 10-year anniversary about a month ago. We have been FDA cleared for treatment of panic attacks and panic disorder since 2013, and for PTSD since 2018. So Freespera is a prescription digital therapeutic. It has to be authorized or prescribed by a licensed healthcare professional. Non-physicians who are licensed can authorize its use. And Freespera is aimed at normalizing dysfunctional breathing that exists in people with panic-related conditions, including PTSD. Not widely known, but there's significant overlap between the two conditions. And Freespera consists of really several interlocking components. What you see in the little photograph here is a medical device. We are considered a Class 2 medical device. You see a small respiratory sensor and a nasal cannula. The patient breathes through that nasal, and we're measuring their breath-to-breath respiratory physiology, their respiratory rate and their exhaled carbon dioxide levels. I'll address that briefly in a minute. That is obtained through the sensor is then displayed on a simple tablet computer, and the job of the user is really pretty simple. It's to match their breathing, to sync their breathing to a rising and falling audio tone, to modify their respiratory air intake, their respiratory volume to normalize their CO2 level. And while that's done, the data is all being so that it's ported to the patient for immediate feedback, but also it's collected so that we have an opportunity at the individual patient level, but also at large group levels to kind of see how treatment exists. So it's used twice daily. So it's really kind of an example of what we talked about as a technology-mediated care. It's what we call asynchronous. In other words, the patient is using it not in front of or in conjunction with their provider. And it is supported by health coaching. So we have a health coach that teaches the patient initially how and why to use the system. And then on a weekly basis through the month of its use, we guide them through the experience. We promote adherence. We answer questions. We give tips about how to incorporate new learnings into daily behavior. So a simple way of putting this is we're helping people with specific conditions normalize dysfunctional or dysregulated breathing, which is really closely associated with developing and unfortunately maintaining the symptoms of both panic and PTSD. We go to our next slide, please. So one of the things that we talk about, and very interested in a conversation that focuses to a great extent on primary care integration. Panic-related conditions have a very strong physiological component. So we're talking about symptoms like shortness of breath, chest tightness, sweating, trembling. Psychologically, it's a fear of losing control, a sense of being kind of detached from yourself. So when you look at somebody who's having chest pain and racing heartbeat, they are not initially thinking of psychological symptoms. They say, let me get to the emergency room. I think something's wrong with my heart. And what happens is we have a population of folks who typically engage in a great deal of what I call medical churn, trips to the emergency room, trips to primary care, specialty. They get a lot of tests. And when heart health has been ruled out as a contributing factor, they tend to kind of meander. They may or may not have behavioral health circumstances. So we are kind of the physiological of these conditions by teaching people how to normalize their dysfunctional breathing. It's beyond the scope of this meeting to kind of talk about the science about carbon dioxide and oxygen balance and its relation to brain networks, but it's a significant contributor to these conditions and to its overutilization in the medical sector. And these tend to be chronic conditions and very, very costly to the system, as well as greatly impairing life experiences. And our next slide, please. This is really kind of a graphical depiction of the normalization of somebody's respiratory style over the therapeutic month. If you look on the left-hand side, you see this very jagged green line. That's somebody who's breathing in a very fast and erratic manner. Respiratory rate probably greater than 20 when most of us breathe around 10 respirations per minute. The blue zone you see up ahead, up above, is the normal range of exhaled CO2 levels, significantly below normal. In the middle, you see somebody who's practiced for 7 days. This is an actual graphs from a patient with pretty severe panic disorder. You see how much the green has smoothed out. This is a person who is now sinking and smoothing down their respiratory style. They're breathing with their belly and not with their upper chest. Their exhaled CO2 level is still significantly below normal, but they're a week into the intervention. We look at this same patient at 28 days, 4 weeks of twice daily care, now breathing at a very slow 6 respirations per minute, and their respiratory rate is very smooth and steady. Their exhaled CO2 level is consistently in the normal zone. But I want to stress that the point is not to produce a pretty graph or a pictorial a representation of somebody whose breathing has changed, but individuals who will do this regularly for a month, about 80% of people will have really clinically meaningful reductions in their panic or PTSD symptoms, and that those clinical benefits in our actual research have been maintained, measured out to a year for panic-related conditions and 6 months for PTSD. Our next slide, please. I'm going to give you a very quick tour through some of our clinical trials, and I think stress here, these are 3 independent clinical trials conducted at different times, different locations. And that very elevated graph you see on the left-hand side are people who start this intervention with moderately severe to severe panic symptoms. And in the middle, within 4 weeks, their clinical symptoms have gone down massively. So you see that dotted line across the middle. That's considered to be about the remission level of panic symptoms. So people have gone from severely symptomatic to remission within 28 days. And what's striking across this independent research is that clinical benefit on your far right has been maintained out to a full year post-treatment. So, kind of depict a rapid treatment, rapid response, and maintenance of that benefit out to a full year post-treatment. We go to our next slide, please. We then looked at PTSD as a related condition, not really widely known, but about 75% of people with PTSD have panic symptoms as part of their symptom complex, and their panic tends to be triggered by traumatic reminders. So at the Palo Alto VA, the Palo Alto VA conducted this study. I think what's really notable here is that for a population with a 19-year average duration of post-traumatic stress disorder, over 80% of them had clinically meaningful symptom reductions a full half year post-treatment. 50% were judged by the study clinicians to be in remission, i.e. they no longer qualified for the diagnosis of PTSD, and their adherence was very strong at 77%. One of the things that I think is supported by the coaching as also by the really pretty rapid reduction in subjective symptoms that fosters treatment adherence for this use at home intervention. If we go to our next slide, part of our data analytics gives us the ability to look at not only how people did in clinical trials, but how they do in the real world. And this is a quick depiction of a paper that I published in November that looked at about 1,400 patients with panic disorder. And in that population, this group had over a 50% reduction in their panic symptoms at 28 days. When we looked at about 175 patients with PTSD, about a 40% reduction in their PTSD symptoms. And again, this very strong treatment adherence. So I think a couple of things that I want to kind of bring to a close here. A use at home intervention for specific conditions connected to their referring healthcare professional who gets an end of treatment report. One of the things that's a real challenge in primary care and medical is that rapid access to health professionals who can provide mental health care is really significantly limited in this country. And this is an intervention that can get from identification to actual first use by the patient, typically within 10 days. It's used at home. The clinician is looped in. And we are also looking at both clinical as well as economic outcomes. We have one project that was done with a major health insurer who were able to find about a 35% reduction in any reason medical spending a year following this treatment. What we typically see are reductions in emergency room visits and pharmaceutical costs and in patient visits with a variety of physicians. We are now also looking at another one of our health plan members, and we're finding comparable savings. So, what we see here is a really pretty simple to use intervention done at home. There are many people who don't have access to a mental health professional, who would rather have a therapy that does not require them to, kind of delve into their traumatic memories, and that can build self-management skills that they develop during the actual formal treatment, but they bring with them following their month of use at home. And our next slide, please. We are ready to turn it over to Benny.
Hi, how are you? I'm Benny Aloof. I'm the Chief Medical Officer of Limbix, where we develop digital therapeutics for adolescent mental health. I'm a pediatrician by trade. I've been in Limbix for about 2 years now. I'll take the next slide, please. So SparkRX is a digital therapeutic. It's a software as a medical device that delivers cognitive behavioral therapy through a 5-week session to manage and treat adolescent depressive symptoms. We're not a cleared device. We're currently commercialized under the enforcement policy for digital health devices for treating psychiatric disorders during the COVID pandemic. But we are currently working through the pre-market notification for FDA review and clearance. What we do is we provide what akin to what a patient would get through face-to-face cognitive behavioral therapy with a therapist, but do it through software, do it through their phone, do it through an app. So that way it is convenient to them. It's delivered when and where they need it most. It's very interactive. It's very engaging. There's a lot of gamification. There's a reward system for accomplishing certain tasks and levels. It walks them through psychoeducational component, teaching them about how mood affects behavior and behavior affects mood, teaches them different acronyms and like the TRAP model, trigger response avoidance patterns that people might take part in, teaches them coping mechanisms. There's a wellness component with grounding exercises, and also monitors them on a weekly basis. In addition to that, it also has a feedback loop to the provider that is offering it, to give them updates in terms of engagement as well as clinical outcomes. Unlike Freespira that Bob was talking about, we're not a connected device, so we are purely delivered through the software and through the app. And that's all I'm going to say about the SparkRX, because we want to talk about integrating behavioral health into the primary care practice. So we're very fortunate to have Dr. Godquitz with us, who's a pediatrician in Western Pennsylvania, who is one of the doctors, one of the pediatricians that has incorporated SparkRX during the enforcement policy, where we've been able to commercialize it, into her practice. So I'd like to introduce her and go to the next slide and have her talk to folks about how she uses this digital device for her patients that she identifies could benefit from the therapy. So Dawn, I'll hand it over to you.
So if I can, it worked. Hi, thank you very much for allowing me to speak at this. A little bit about myself. I'm Donna Godquitz, and as Benny said, I'm in Western Pennsylvania with UPMC. I'm a pediatrician with actually 25 years of experience now in primary care, with an interest in behavioral health, but also transitioned to college and adult care and educational programs for pediatricians in behavioral health, including lifestyle and medication management. So I've been very involved with UPMC. I've worked on protocols for our CCP pediatricians within the system, including our suicidality and eating disorders protocols, SSRI initiation, plans of care, safety planning, and basically better recognition of anxiety, depression, and ADHD in the primary care setting. So looking towards intervention early to help prevent the need for medication or issues with school performance. The problem is pediatric practices have become, as we know, incredibly busy, primary care in general, and there's an increased need to see patients urgently and quickly. We're not educating like we used to. The parents are coming in, there's a lot of walk-in, and unfortunately, despite the fact that we're screening for anxiety and depression, there's usually little time to make a difference and educate early before the crisis happens. So when questions are asked or screeners are positive, we're often faced with waiting lists for counselors, a paucity of child psychiatrists, mid-level providers who are really trying to amp up in psychiatric care, but with very varied training, especially for children, and pediatricians who were never trained for psychiatry. Many of us have taken this on and learned how to manage psychiatric issues as best we can. But we're often pressured to kind of decrease time in the room and still do not have the resources for adequate referral. There's nothing worse really for a pediatrician than identifying a problem and having no solution that they're comfortable with. For some, it's easier to ask minimal questions and just hope it gets better. When patients live in poorer communities or rural areas, the problem's even greater because some cultures are opposed to discussing mental health. Some see counseling as too much time or not worth the effort. And often kids understand and seek help online since they can't access it, which is not always the best information. It's not always science-based. There's so many apps and websites available, but not approved or regulated. I'm always a fan of in-person counseling, and Benny can tell you at the beginning, I'm like, well, this was a while ago before I knew this team and much about the app. I think in-person helps with rapport and initiation and accountability, but I've been using SparkRX with my patients now for over a year, and I've actually found it incredibly useful over time for several reasons. So I just have a couple of little slides. I'm confident when I recommend this product, and mainly because of the people that have developed it that are medically based, and I've met them now and know how much they care to provide a product that's safe and easy to use. So, the evidence-based proven methods to assess and find ways to improve pediatric depression. It's developed by people who care, like what I mentioned, and they want what's best for our kids. It implements changes to reflect the needs of the patients. And so a lot of times, it'll ask like interests and things to try to hone in on what's going to work for them. But they also are continuously looking for input from the pediatricians to perfect their product. There's crisis lines that are easily accessible to users and shows me if they're improving or not. There's options for PCPs to see the patient initiation and follow through using the product. What I like the most is that I don't have to do any onboarding. I basically have a card with this little QR code, and it's just kind of like, hey, you know, and I give a little blurb, but I even have these little booklets that explain the safety of the product to the parents and give more information. So this is truly minimal work on the part of the provider and something that I feel I can safely offer. So really the amount of time is, hey, if you want, you should try this. I've done it myself. It's a nice way to learn some strategies to handle depression. I can see if you're using it, but I'm not going to be following in real time. So if you're struggling, please use your crisis lines and safety plans so they know that from the beginning and the parent knows that too. The other thing that's been really interesting over time on the next slide is the populations that this has actually been the most useful in my practice. So it's useful in general, but especially those resistant to counseling. A lot of kids just don't want to talk to somebody, and they'll say outright, I don't feel comfortable talking to people I don't know. Well, they don't have to because they have a little robot and they engage with that. So it's something that they can try to use. The ones who have a long wait for counseling, sometimes kids, their parents are not keen on counseling, but yet this generation is starting to realize that mental health is important. So there's this parent that's like, this is ridiculous, we don't want to do it, but a kid that's really interested. And often the parents are fine with this because it's an app on the phone. Those who live far from services, families that are more culturally resistant to mental health care, because parents, again, a lot of times are fine with the app. Sometimes it's kids who want something in addition to the counselor that they already have, because this is something they can do personally and follow through and get little rewards for. So it almost reinforces the skills that they're learning. Sometimes it's been kids who've had lots of counseling in the past, but it's been a while, and this is a reminder of the skills in a different format. But especially some of my socially anxious kids, because they're really nervous with people, but they're a lot more comfortable with an app and a little robot that kind of helps you along, and you can build your campsite and feel good about that. So the one other thing that, you know, I wanted to mention, especially given that there's so many varied populations that this has been useful for, is that not being able to utilize insurance benefits for this in a lot of places, especially with medical assistance, is hard, because I almost feel like I have to pick and choose who's able to use this. And in fact, it's the patients in the rural communities or on medical assistance that oftentimes do need it most. So it's something that right now I've been able to do for everyone, but I feel like it would break my heart to not be able to do that. So I just wanted to mention that as part of this discussion. And I just had a very brief scenario. I could probably do this on any given day, but just last week I had a 13-year-old girl with low self-esteem and anxiety, was using marijuana but didn't want to. It was something her friends wanted her to try, said should feel better. Always an A student, wanted to do well, but the transition to high school and peer pressure created this vicious cycle of poor choices, lack of sleep, and depressive symptoms. So we assessed for safety, and I gave options for counseling, many of which I knew would take months. And we talked about sleep and ways to decrease marijuana use. But I gave her the SparkRX card, and I was like, look, you know, it's a company I know and I trust them. It's a product that pediatricians help to develop. And by the end of the day, I was notified by email that my patient had engaged with the app. And at her follow-up, we'll be able to see how far she goes with the app, talk about her progress. I found even the ones that don't go all the way through have gained something if they then hook up with counseling. And I think that's a win, even if they don't go all the way through the program. A lot of times the mother will then see benefits of counseling, be more likely to make the call. And my patient will already have some tools when she starts counseling, and likely will heal faster in that way and understand what CBT is. So I think, like, you know, visuals of progression are super helpful for kids. So when you go to counseling, you come out and you're like, it was a good session, it was a bad session, but this is actually like you're moving along a continuum, like in a game. And I think it's a way to feel success when you're struggling in school and struggling with friends. Like, this is something you're moving forward in. So it's been very helpful for me. I am not one to promote things. This is the first time I've ever done that, but I can honestly say that I went into it cautiously, looked a lot into it, used it, gave it a chance, used it myself, and I have no concerns at all. These guys have been great, and it's been a huge help for my patients. And I think I need to go over to Chris.
Thank you so much, Dawn, and thank you both, Bob, Benny, Lanny, and Pooja. I think this has been a really enlightening discussion so far, really highlighted a lot of important experiences and values that these types of solutions can bring to everybody involved, particularly the patients, but also the care teams as well. So I wanted to kind of follow up a little bit, maybe starting with you, Bob, about kind of what you're hearing from your primary care partners. I think we heard a little bit from Dawn, but what are the kind of key values that your primary care partners are clamoring for when they're looking to integrate these types of care and solutions? And what ways can solutions like yours support and enhance them?
Yeah, I think one of the things that we hear often is the need to have more tools in the toolkit. We know that most of the mental health treatment in this country is provided by primary care physicians, and most of that consists of psychotropic medication, does an awful lot of good, but primary care physicians, have not been extensively trained like psychiatrists, and so with more complicated patients, there's the need to refer out, and then we have the access problem. It's not unusual in many of the communities that we work in that we hear in primary care that it takes 4 to 6 weeks to a first appointment to an available practitioner. There are a lot of practitioners in this country who do not take any insurance, and so you have time as well as economic barriers. There are a lot of patients who are also interested in non-medication approaches to their mental health condition. The side effect burden for some medications, unfortunately, the best vetted medications for both panic and PTSD are antidepressants that can be very effective for many people, but they're slow to work. There's a pretty high side effect burden. There are a lot of people who discontinue, and many times primary care physicians are reluctant to really kind of push dosage to get somebody to a therapeutic level, and then they may treat for a while and then engage a psychiatric colleague to manage medication. It's hard to find talk therapists available in communities. Tele has made a real difference in kind of overcoming some of the geographic barriers to care. But I think, when you look at the two companies we've been talking about today, I think one of the things that really stands out are the efforts to really increase access and to offer treatments that can be available to patients at their choosing, as opposed to needing to drive across Houston at 2:00 in the afternoon to get to my office.
That makes complete sense. We hear a lot of those aspects as well. Benny, anything to add from your perspective?
No, I mean, I think 4 to 6 weeks is low during the, it's even higher than that. We're hearing of months, and Dawn can speak to that as well. But it's months. These kids, they get to a point of escalation and crisis where they end up in an emergency room. They sometimes get boarded in emergency rooms for weeks. When I was working in the emergency room, it used to be maybe overnight stay, and then they'd get placement, or you deem them safe to go home. Now they're spending weeks on a gurney with just curtains protecting them from the beds around them in an emergency room, which is why some of the children's hospitals throughout the country have called for a national emergency that they simply don't have acute care beds. These are opportunities to provide these treatments early at the primary care office as part of the integrated system and an integrated care plan, and potentially prevent these catastrophic events.
Absolutely. And Dawn, I think, everything in your kind of piece actually hit, I think, every single value stream that was on our return on health framework, right? From outcomes to access to experiences for the patients, their caregivers, the care teams, then even, in terms of operations and financing. But, some of the things that we hear from some of the practices we talk to is sometimes this can feel like drinking from a fire hose. it can feel like a lot. What, from your point of view, are kind of the key value streams or key things that are kind of linchpins or really important to focus on, particularly for these digital therapeutics solutions to focus on, to really kind of have the impact that we're all striving for, so we're not having the experiences that I think Benny kind of outlined, hopefully in the nearer term?
So I work with a lot of groups that work on suicidality and pretty intense type of things at Western Psychiatric. But they're probably sick of hearing me say it, but we have to look upstream, because yes, we have to have things available for people downstream when they're in a crisis. But as a pediatrician, if you ask the questions, a lot of times you can tell somebody's heading that direction way early. A digital therapeutic, they might not feel like they need counseling yet, and the parent may not. And sometimes the parents have similar executive function challenges as the kids. So trying to get in with a counselor and trying to do things is like overwhelming between all the other things. But I feel like it's so easy to enact this that if we're going to screen, which a lot of us do, sometimes you're going to catch those kids upstream and prevent the crisis. And I think we do need to focus on that. And I think digital therapeutics are super good for all the things I mentioned before, but it's also an option for people upstream. So I have had kids that even if they don't score that high, when I talk to them, I get the sense, something's up. I've had them do it. And sometimes those are the ones that go all the way through. So.
Yeah,
Absolutely.
we get requests from parents quite a bit directly for how they can get access, and that's exactly what we hear from the parents. They know something is going on, but the kid doesn't want to go see a therapist. They don't feel comfortable with it, and just the other day, a parent requested information, and they wanted something that was more suitable for what their child is ready to process. So something that is more technical, something that is more personable, something that's on their phone is something they're more easily able to process, especially in adolescence, than to, and we do hear a lot of stories where they start with, I don't know if this is Dawn's experience as well, they'll start with the app, and then I will help them open up. It will help them be able to identify and recognize what's going on. And then they will move on to that face-to-face therapy, because, as you said earlier, there's not the intention to replace, the intention is to augment.
Absolutely. So I think we've heard a lot about communication when it comes to this. Both, Lanny and Pooja talked about perhaps confusion in the general space about what digital therapeutics are and how they fit and rely in comparison to some of these others. So I'd love to hear, and maybe starting with you, Don, and we can go through, is how should primary care physicians and practices gauge patients, and when it comes to adolescents, both it may be the adolescents as well as caregivers or parents in the process about potentially having the conversations about using some of these therapeutics, as well as just communicating what they are and differentiating them perhaps from some of the other things that are in the space that, Donna, as you noted, I think they may just be Google searching things because they're still trying to find ways to get access or get support. How do you facilitate that communication in a way that is engaging and brings them in and creates a good experience for them as you're trying to figure out the best treatment options for them?
So I think a big part of this is a lot of offices, and ours included, do some universal screenings so we get a sense if something's up. I have taught a lot of people to ask our physical questions a little bit differently to pick up if something may be on the horizon. Some kids like to score everything a 0, but you can tell something's up. So we've worked hard on that. I don't find it hard to get engagement, especially since, like, the little blurb that I mentioned, I'm just kind of like, hey, sometimes I've even said to kids that are super resistant, I'm like, hey, listen, just humor me, try it, see how it goes. And I say it playfully because, but I also will say, like, I did it myself. I used it, and I'm very comfortable with it. There's nothing there that has me concerned. I usually make it quite clear that I'm not going to see their scores unless I look. So everything else is the same. They've got a safety plan, crisis lines. But I honestly think just me saying I used it, I'm trusted, it's fine. And I also tell them I'm not going to be disappointed. If you don't like it, that's okay. I said, but tell me because I'll let Benny know. So, I think when I do it in a playful way like that, I have no problem getting engagement, at least to try. And I do agree, there's a lot of kids that start it and realize, oh, this is like what counseling will do for me. And then it clicks and they're like, okay, I get it. So that's how I approach.
Great. Bob, what about on your end, especially the aspect about how to differentiate some of these solutions from other things that people may be seeing and
Sure.
confusing them? How do you suggest your practice partners communicate that in a way that makes sense and is engaging for their patients?
Sure. One of the ways, for us that we do with practitioners is we say, we're FDA cleared for specific conditions, and that means the research on the effectiveness and the safety of this intervention has really been established. And that's what differentiates us from the 10 to 20 to 30,000 wellness apps that are out there, in the general marketplace. And we stay, for many reasons, not the least of which is our FDA clearance, is we stay on point with the conditions that we know we have studied and have reason to believe we can be effective for. So we will screen out, for example, an individual who has OCD without panic attacks. We will screen that out and say we have no evidence or understanding of the brain that would suggest that we would be helpful for you. So we don't want to offer a treatment for a condition that we don't think it has, it has benefit for. And so I think from the practitioner level, having a solid evidence base, we frequently share either summaries or full research papers, from peer-reviewed journals that establish our effectiveness, that we also, indicate to the practitioner that you will get a report that will, inform you of your client's adherence and of their symptomatic change within the course of treatment. You'll get notes from the health coach that will, kind of guide you about the experience of your patient, so that the practitioner then develops kind of a database of their own about, this is the kind of person that I think for Spiro. So, not uncommon for somebody to say, I know I'm having these traumatic flashbacks. I tried antidepressants. They made me feel worse rather than better. And I don't want to talk about my traumatic experience. Here is a free Spiro patient. They may have somebody who has recurrent panic attacks, who's had cardiac test after cardiac test. There's no evidence of heart disease, but I'm not going to go see a shrink. Well, here's a way that you can have an intervention that's going to address your physiological distress, will be within your comfort level. So those are some of the kinds of guidances that we give in our collaboration with our physician partners.
Lani, anything to add to that? Anything you've heard from some of your other members that are really important as folks are communicating about these solutions?
Yeah, I mean, I would agree with everything that everyone else has said. I think, it's been important as an industry to identify practitioners, like Dawn, for example, who are champions of this type of technology that then can help their colleagues understand the benefits of use. So that's been really, really important, I think, for member companies. I also think that it's been important from the standpoint of patients to be able to learn about the technologies and have kind of back and forth informative conversations with their clinicians, right? Like, this is something that I've tried. I've heard from several patients. We have a patient advisory council at DTA that have said, I took my experience to my provider and had a conversation with that provider who didn't yet know about this type of technology. But once I explained it to them, they wanted to know more. So I think that, the education kind of goes both ways between clinician and patient, especially with an industry that is as new as, the technology is not that new, but, this information sharing is new. So, yeah.
Absolutely. And a few have mentioned, the concept of And I think Donna is one of your positive bullet points from Limbics, but engaging the care teams, especially, you know, the physicians, about informing how these solutions work, especially within their workflows and other kind of dynamics. How can digital therapeutic companies work to get physicians, the care team members, more involved in the development of your solutions? I don't know, Benny, since you did such a good job of identifying Don, maybe we could start with you and then we can move over from there.
Yeah, that's been a huge challenge, right? There are several challenges for this industry, and one of the big challenges is clinician adoption. You have the early adopters like Dawn. What I like to call them is early adapters, and we like to reach out to them and find out from them through UXR. How do you adapt this into your workflow, right? Because you just heard how, especially primary care providers, they spend a tremendous amount of time going through all the required guidelines and questionnaires, and there are always positives that come up that they need to address. Very short period of time that they're able to do all that in. How do they incorporate something like this into their workflow? But also, how do they understand the different types of devices and therapies that are out there? You just saw two devices. One is connected. One has their own coaches or counselors that are used, whereas another is as a freestanding software as a medical device. That's another thing that clinicians need to learn about. It's not something you learn in medical school. It's not something you learn in residency. It's not in any of, at least that I'm aware of, clinically published guidelines from the medical societies and professional societies. And so, that's why we're here today, right? You start off with teaching about what are digital therapeutics, what are the different types of digital therapeutics, and then speaking to clinicians and key opinion leaders and early adapters. How do you use this? It's not so straightforward for a lot of folks, and that's where we're finding some difficulty getting in there. But it's slowly getting there. We love talking to medical students and residents, especially because they're the ones that are going to be using it.
Excellent, Donna. Anything to add from your perspective?
Yeah, just briefly, I would say that the people who've adopted it are the people that are seeing me use it in the office. And I think just having somebody that's doing it and then people are seeing it's available and how easy it is makes it simpler. I think the other thing is a lot of times we do continuing education and people are just, what can I do? Where can I send them? And if you and I've done that with Limbics, because it's very easy to adopt. And so in a situation like that, I'm like, hey, do you guys know that this exists? And, I'll mention it in the context of, hey, this is a nice opportunity. It's real easy to enact. You don't have to do a lot of explaining. They've really made it streamlined, because I've worked with other apps like in research protocols and things where even just having to input 4 things is too much. This, you do nothing except say, hey. So I think those situations where people are looking for an option are great places. And then if you get one person to pick it up, it moves forward.
Absolutely. I think we've heard a lot about just increasing attention and education in general. I think, Don, you talked about this too, about just integrative care in general, right? Recognizing these needs, but these models have existed for quite a while. But I think the implementation and ability to access actionable solutions within that space has continued to grow too, which then sparks the questions of okay, I have this information, now what do I do next? Which then leads into how some of these types of digital therapeutics can play into that role, right? Bob, anything to add as part of Carl's journey and engaging your primary care partners?
Yeah, I want to echo what Dawn said, how important it is to be friendly to the workflow of practitioners and to really function as a collaborator. That we are adjunctive to the primary delivery of healthcare. We are not competing for, we're not looking to replace therapy. What we hear from many practicing psychotherapists is that somebody who does our treatment actually is a better consumer of psychotherapy. They are not so preoccupied about when the next panic attack is going to occur, or feeling overwhelmed by a traumatic trigger. And so they're able to engage. And at the same time, caseloads are very, very demanding. And occasionally, we'll hear about a patient who'll talk to their psychiatrist and say, doc, I'm done. I'm better. I'll call you if I need you, which then opens up, the slot for that person to get in another patient more rapidly. So I think from the practitioner's standpoint, having options where there's good communication, where there's little impact on workflow in the office, and that provides positive outcomes is really the way that all of this dials in when it's effective.
Yeah, there is evidence out there that really supports that, Bob. That it can decompress some of the workload for the therapists that are being overwhelmed right now. So once it's incorporated into their workflow, it can actually free up a lot of their time, because folks are getting therapy in a virtual space through the device, without necessarily needing their direct intervention at the time. It allows for that asynchronous ability to be treated, and that not only allows you to free up your wait list, which we hear from therapists are in the hundreds, but also perhaps allows you to spend more time with your patients when you do see them. And that's, it was mentioned earlier also as part of the step therapy. Finding where in that step therapy you can insert the digital therapeutic is critical, because in the long run it will save time.
Excellent. So I think we've heard a lot about all the great things that digital therapeutics can do, and I think we have some really great examples right between Limbix and Fruspera. But I think we also know that these solutions continue to evolve and look to improve and increase their value. And maybe for Lanny and Pooja, talk a little bit about, from some of the other members that you all have, ways that they're looking to improve or expand their solutions to better address some of these kind of value propositions that Don and Bob and Benny have kind of outlined as the digital therapeutic space continues to kind of evolve and improve upon itself.
Yeah, so Chris, you're talking about how other digital therapeutics companies are delivering upon beyond Fruspera, beyond Limbix. What are they doing?
As a whole, right? Like, I think these are a couple of examples, but we kind of want to raise all boats, right, for them to work on some of these aspects. Are there other ways or that digital therapeutic companies are looking to improve their solutions, or other things that you all would suggest that they focus on based on some of the things that we've either talked about today, or other value streams that we may not have touched on?
Totally. Yeah, I think we've talked about this today, but involving the clinician in the design and development of the product is key. I think that harks to understanding their workflow very closely. Other points, Lonnie, what else comes to mind for you?
Yeah, I mean, I would say similarly to involving the clinician early and often, involving the patient early and often is very much a way to improve the offering from a digital therapeutic company. I think our member companies are looking to increase their value to their patient populations that they serve all the time. I think one sticking point that doesn't have to do with necessarily improving the service is really the access piece, right? We're all working very hard in terms of the, lifting all boats to provide access to those populations that we've been talking about this whole time. And that's not an easy task, but I think that's, to get the value there, we really have to be working hard with the stakeholders that make the decisions about coverage, as well as, so that our patients can benefit from the value that these tools provide. They need to be paid for. So that's something that, we're working hard on together.
Absolutely. I think one thing that we've heard often, and I think it's really important to focus on the evidence base in terms of outcomes, right? But I think, Lanny, you were talking a little bit about the financing piece. both from digital therapeutic company side of things, but I think it's also important to note their perspectives from the practices as well to ensure that they can both include and sustain them within their broader models, not just operationally, but financially as well. And I think we noted in our report, that's an area that we've seen a gap in terms of really closing. And I think Bobby talked a little bit about that kind of connection, right, between preventing hospital readmissions or other ways to help with financing. But I think it's a space that we've at least seen more effort is needed to be able to kind of grow that evidence base and communicate it back out to the practices so they can feel confident that it works both operationally and financially within their practice models. I don't know if anybody has any kind of additional thoughts about ways that companies like yourselves or members that you all have, Lanny and Pooja, can help with growing that evidence base that I think will also help increase comfortability by these practices to start using these technologies.
We certainly see that in instances where value-based care is in the equation, where there's an alignment between the payer and practitioner, where there are really concerted efforts at looking at clinical and economic efficiency. So metrics like reducing unnecessary emergency room visits or psychiatric hospitalizations, or to be able to offer treatments with very good side effect profiles. And for many reasons, Dawn talked about the dilemma of screening for a condition that you don't have a ready solution for. I think another thing that's a kind of a major issue where mind and body meet is how much health anxiety plays in, and how much time is involved in medical practices dealing with somebody who has lingering mental health needs that drive medical overutilization. Doc, it felt like my heart was racing. I think I need to go to the emergency room again, even though they've told me 6 times I don't have a heart condition. So for many reasons, a solution that can decrease that churn from the patient standpoint, the doctor standpoint, and the payer standpoint, that's where this stuff converges in a way that has really great merit.
And we've heard that a lot with a better alignment between integrative care and value-based care versus kind of fee-for-service dynamic. But it's a space we continue to kind of have conversations about because it's still difficult to isolate the exact value that some of these specific changes are doing within the broader kind of value-based care arrangements that many of these entities are pursuing. Any other thoughts, Benny, or others, from kind of how you match I think the good outcomes-based evidence with some of these financial components?
Yeah, so that is something that we're very interested in looking at. Again, emergency room utilization, hospitalization, rehospitalization. The thing about mental health too, though, especially in pediatrics, is it tends to be the peak when mental health conditions are diagnosed, but only about half, and in some populations even less than half, receive therapy during that time. And what that translates into future adulthood, where you're at higher risk for substance use disorder, you're at higher risk for homelessness, higher risk for not having a job or difficulty holding down a job, and so forth. Those are the intangibles that our society is grappling with right now, that we're really experiencing, not just as a result of the pandemic, but just in terms of how things have shifted. And it's very important to look at these ROI measures, because the truth is that's how a lot of health plans evaluate whether they're going to reimburse for you or not. But I think we also need, as a society, to step beyond that and say, if we take these, millions and millions of adolescents that are, once they're diagnosed, we're not really able to reach them for therapy. We have these products that are able to treat them, but we're not going to be reimbursing for them. What consequences does that have to us, as a society? Because a lot of the the cost savings measures are somewhat in the short term, and health plans tend to kind of think in the short term because there's churn, and that 12-year-old may not be in my plan in a couple of years. So they really need to go beyond that and say, what can we do better for society in helping these teens and treat them early so they don't suffer the consequences of mental illness as adults, which are, as we see, far-reaching.
Yeah, and that's something that in the report I mentioned earlier in this session, talked a little bit about identifying some of these broader measures of value that move beyond some of the things that we tend to focus on. But unfortunately, I think also, as you noted, do need to work backwards to fit some of them into these other kind of systems. And I think that's a challenge that we're still trying to work through. And the AMA and the collaborative continue to have conversations with large employers, self-insured employers, national health plans to figure out best ways to match this broader value, which I think people are recognizing, to these systems, because that's just kind of how it's structured and the ways that we have to kind of navigate, and that does create a lot of difficulty. So I know we're about at time, but I did want to just throw out one additional question. Are barriers that you all face, Benny, at your organizations, Bob at yours, and anything, Lanny and Pooja, you might be seeing for other members that will continue to face as companies, as organizations, or what are some ways that you are working to try to overcome them, or other solutions that may be out of your control that would be really helpful to kind of create this more seamless experience that you are striving to enable? So I don't know who may want to start with that question, but.
Well, I'll jump in. I know Benny and I have been on multiple occasions in the halls of Congress talking to members and their staff about digital therapeutics, about the barriers that are as simple or as profound as the lack of adequate coding to recognize what we do. And invariably, when we're in those offices, either a member of Congress or one of the staffers will say, yeah, that was me. That's my niece. I'm a veteran. I have PTSD. I have kids who were struggling. That when we get at that personal level, we're looking at this big regulatory framework. What we really find is that the message resonates, and we're continuing to work to increase, recognition and changing the reimbursement structure so that all we really ask for is a seat at the table. We'll prove our outcomes because we collect all of our metrics. Just give us a seat at the table.
Yeah, I agree. I spoke about patients and parents reaching out to us. Echo what Bob said. We speak to folks in the halls of Congress, and everybody can relate, right? Everybody has either a personal story or very close relative or loved one story. Patients and providers are our biggest advocates. The biggest issue is pathways to reimbursement. These companies, many of them started with venture capital, but eventually they have to have the legislation, the Access to Prescription Digital Therapeutics Act to help create a benefit category that will lead to CMS coding and reimbursement to get on that fee schedule, and for health plans to start also reimbursing downstream from CMS in the commercial space. We have employers that are asking for help. They're recognizing that mental health impacts not just the employees, but the employees' dependents. But it's really getting that reimbursement, and that's probably our biggest battle.
Lanny, Pooja, anything that Bob or Benny didn't mention in terms of things that you all are addressing or working to address?
No, I don't think so. I would just echo both Bob and Benny and say that, the DTA is committed to supporting our member companies through, working hand in hand with folks on the Hill. In 2 weeks, we'll be there again, right? So that's what we're doing. We're all working hard to get that seat at the table, like Bob said, and we look forward to continuing that work and getting this legislation passed for the betterment of the industry and for our members. Yeah,
I'll just add the implementation of digital therapeutics and clinical practice guidelines is an important future step, a barrier that we're working to overcome as well.
Excellent. Well, I want to thank you all again. If we want to bring up the slide deck once again, just as a brief recap for everybody, these are just some key take-home messages. I'm not going to go through and read all of them, but I think they align with many things that we talked about, both in the presentations as well as in our group discussion, including how digital therapeutics can be effective and these existing evidence-based behavioral health integration models, the fact that digital therapeutics can be used at different levels within the primary care settings, and that really it's essential to think about practice workflows as well as just digital literacy, both for patients and these care teams, and how these solutions can be integrated into the broader care continuum. So with that, I just want to really thank you all again for a great discussion. It's just been really great and hope everybody found it as enlightening as I did. And I will pass it. This is just contact information, both for our digital health team as well as our behavioral health integration team, which sits within our practice sustainability unit. And with that, I'll pass it back over to you, Laura.
Hi, thank you all so much. Thank you to all our presenters and thank you to the behavioral health integration team for driving this excellent session. As we close, I'll just remind you all that our sessions are published on both our Future of Health Immersion Program website and also our YouTube channel. You'll receive a follow-up email for attending this session and you can access the site there. And with that, thank you all so much for joining and have a great day.